Diabetes insipidus and SIADH, syndrome of inappropriate antidiuretic hormone, are two distinct conditions that involve the regulation of water balance in the body but affect it in opposite ways. With diabetes insipidus, patients often experience intense thirst and produce large volumes of dilute urine, while those with SIADH retain water due to excessive release of antidiuretic hormone, leading to reduced urination and a potential for fluid overload. Treatment for diabetes insipidus may include medications that reduce urine output, while management of SIADH typically involves fluid restriction and addressing the underlying cause. Risk factors for diabetes insipidus include damage to the hypothalamus or pituitary gland, whereas various conditions like certain cancers, lung disorders, or brain injuries can predispose someone to SIADH. Here's a deeper dive into the nuanced aspects of each disease, highlighting their unique features and management strategies. Cause of condition: hormone deficiency versus hormone excess. Diabetes insipidus and syndrome of inappropriate antidiuretic hormone SIADH are polar opposites concerning body fluid regulation and antidiuretic hormone ADH balance. This stems from a deficiency of ADH or its action, leading to copious dilute urine and risk of dehydration, whereas SIH involves an excess of ADH, resulting in concentrated urine and fluid retention, potentially causing hyponatremia. The root causes differ as well. DI can be due to damage to the hypothalamus or kidney, whereas SIH often results from malignancies, CNS disorders, or certain medications, portraying the delicate balance and complexity within endocrine regulation. Volume of urine: polyuria versus oliguria. In differentiating diabetes insipidus from the syndrome of inappropriate antidiuretic hormone secretion SIADH, urine volume is a telling clinical sign. DI is characterized by polyuria, where patients excrete unusually large volumes of dilute urine due to a deficiency of antidiuretic hormone ADH or renal insensitivity to ADH. In stark contrast, SIADH involves oliguria, or reduced urine output, with patients typically producing small amounts of highly concentrated urine because of excessive ADH release or action. These contrasting urine outputs reflect the underlying pathophysiological mechanisms. DI results in an inability to concentrate urine, whereas SIADH leads to an excessive concentration and reduced urine excretion. Recognizing these urine volume patterns aids healthcare professionals in determining the correct diagnosis and treatment pathway. Serum sodium levels: hypernatremia versus hyponatremia. Diabetes insipidus, DI, and syndrome of inappropriate antidiuretic hormone, SIADH, are polar opposites when it comes to serum sodium levels and osmolality. DI, characterized by an inability to concentrate urine, leads to excessive urination and thirst, causing hypernatremia due to the loss of more water than salt. Patients exhibit high serum sodium and plasma osmolality. Conversely, SIADH is associated with excessive release of ADH, leading to water retention, dilution of the blood, and resulting hyponatremia. Here, patients show low serum sodium and decreased plasma osmolality. Accurate differentiation through serum sodium levels is crucial as it directs towards contrasting treatments. DI often requires fluid intake and desmopressin, whereas SIADH is managed by fluid restriction and medications such as tolvaptan. Fluid balance: dehydration versus overhydration. When comparing diabetes insipidus, DI, to syndrome of inappropriate antidiuretic hormone, SIADH, fluid imbalance is a central issue, but with opposite presentations. DI is characterized by an inability to concentrate urine due to insufficient antidiabetic hormone, ADH, or a lack of response to it, resulting in severe dehydration. Patients often present with copious amounts of dilute urine and an incessant thirst. Conversely, SIADH involves excessive release of ADH, leading to water retention and diluted blood sodium levels, causing overhydration. This can result in symptoms like headache, nausea, and in severe cases, cerebral edema. Differentiating the two conditions is critical, as their treatments are diametrically opposed. DI requires fluid intake and ADH replacement, whereas SIADH management includes fluid restriction and addressing the underlying cause of ADH overproduction. Response to water restriction: improvement versus worsening. Diabetes insipidus, DI, and syndrome of inappropriate antidiuretic hormone, SIADH, represent polar opposites in water balance disorders. In DI, the body cannot concentrate urine due to a deficiency in antidiuretic hormone, ADH, or a renal response to it, leading to copious dilute urine. A water restriction test typically improves DI symptoms as the body compensates for reduced intake by conserving water, reducing urine output. Conversely, patients with SIADH have excess ADH, causing water retention and dilutional hyponatremia. Restricting water in SIADH could aggravate the condition, further diluting serum sodium, worsening symptoms, and potentially leading to water intoxication if not monitored carefully.